Hello, I'm John Gribben from the Barts Cancer Institute in London, and welcome to the 12th International Workshop in Non-Hodgkin Lymphoma here in Scottsdale, Arizona. The temperature today was cooler. I think it only reached 100 degrees today, so much cooler than our previous days. We're here with some experts and some committee members from the workshop to be discussing the highlights from day two, and I think we'll all agree that it was a very successful workshop over the last few days. So Wyndham, what do you take as the highlights from what you heard about today?
Well, one of the things that we did differently this time was we had some non-lymphoma specialists come in. And specifically, we had 3 international experts in multiple myeloma. And they spoke about multiple myeloma within the context of how it might apply to lymphoid tumors. And I found it to be a very fascinating discussion because we talked about how does resistance to drugs emerge? And there has been this idea that somehow cells develop a resistant phenotype, and what they showed, and what I think many of us have thought for many years, is that there are in fact many, many different subclones by the time cancers reach a large enough state that they actually cause problems. And what they found was that as they treated the patients with different types of drugs, they found that there was emergence of very small clones from the very start that really became the dominant clone that in fact had a pre-existent resistance phenotype. And that when the patient eventually died, that was the dominant clone. And they also found that as part of this, a number of other things occur. They talked about how MYC activation was perhaps an event that occurs that allows a cell to become more aggressive, to become more independent. And I think all of this has great impact and significance for lymphoid tumors as well. I think probably more likely low-grade tumors, but nonetheless, I found that entire paradigm to be very interesting, and I think it really points out how useful it is to bring different disciplines into a workshop such as this.
Yeah, I agree with you. I mean, you're right, they didn't really say anything so different, but somehow a fresh approach to how they've looked at a similar problem just made us think a little bit differently about our own disease.
Absolutely.
So, Ton, what was the highlight for you today?
Well, you know, the new smart molecules are close to my heart, and I would like to refer to the Idelalisib studies, the PI3 kinase inhibitor, not because you presented that, but it struck me there is, well, with quite a number of patients, more than 100 patients, the Australian study, there's a significant response rate, although it appears to be mainly partial remissions. That's one of the issues that is at stake, with only, I think, 5% CRs. So what you reach there at the end with this single oral drug is patients in PR, they stay in PR for some time, but we are not going to win the war with a single drug like this, of course. That's one thing. So we need to look, and that's the next step maybe for the next workshop, to come up with intelligent combinations to really get rid of the tumor load and get it to minimal residual disease, or even better. Another thing is that these drugs are not without toxicity. I mean, there's a different sort of spectrum of toxicities, different from the conventional chemotherapy-induced toxicity, like alopecia and nausea and vomiting and those sort of things. But in particular diarrhea, which is maybe a problem to several patients with an unknown etiology so far, and in most of the cases manageable. And also granulocytopenia, there's something happening in the bone marrow. So this is not without side effects. But the good thing is that this is, well, we call it all targeted therapy. Now that we know more about the biology of the lymphoma cells in this case, we can more specifically hit, let's say, the proliferation pathway and block that and get to these results.
Well, hopefully we can learn a lot from what's already come from the clinical trials. We can find who are the patients that are going to respond best to it, and just as importantly, who are the patients who may not be good candidates for these types of approaches, so that we can not just use a tailored therapy, but tailor that therapy for the individual patients that need the treatment.
Yes.
Yeah. So Michael, what did you take as the highlight from today?
For me, the highlight today was David Maloney's report on their study with CARs, that means chimeric antigen receptor T cells. And I was always very skeptical about the issues of CARs, but he brought it onto a more scientific ground. First of all, I was surprised that it takes 1 week or 2 weeks until you have the patient's own T cells prepared in such a way that they attack the tumor. And what's fascinating is what a small number of T cells can really kill billions and trillions of tumor cells. Once they have the right antibody, let's say transplanted onto the T cells, and moreover, David Maloney showed that in contrast to the other approaches who used peripheral mononuclear cells, they could show that by really defining the T cell or the CD8 cell in a specific type of differentiation, the central memory cells were the T cells which were the most effective. And what he also showed, if you combine then the transduced central memory CD8 cells together with a limited number of CD4 cells, then the effect is even stronger. Of course, this new approach is not without side effects, and I think the most scaring or frightening side effects both for the patient and for the doctors is the CNS side effects, which reminded me very much of the side effects that we have observed with the bispecific so-called T-engaging antibodies, also CD19, CD3, where at least in the lymphoma patients that I have been treating was really a frightening experience. The patient had problems to speak, the patient couldn't write anymore, and some patients the side effects were so severe that the differential diagnosis was apoplex. I think we still have to learn how to cope with these side effects, but for me the CARs, that's the most potent immunotherapy I've ever experienced.
I think there are several surprises to me. I mean, I think you're right. I think what's very clear is that program is making huge advances by the amount of preclinical work they went into defining how they wanted to do these cells, what was the spacer, what was the co-stimulatory molecule, what T cells they went into. But for me also the surprising feature has been the spectrum of diseases that respond well. I mean, I did not expect when this disease was when these T cells were in their infancy, that it would be very aggressive acute lymphoblastic leukemia and refractory diffuse large B-cell lymphomas that we would be seeing responses. I expected it to be in the more slow-growing, more indolent lymphomas that we would see the best response. And that's not to say that we're not seeing good responses in those other histologies, but we're seeing it right across the spectrum, and I think that's really exciting. Yeah.
That they can control fast-growing tumors like ALL.
Yeah.
That's really surprising.
Particularly when we think that ALL's been not the disease in which we've really thought there's a strong graft versus leukemia effect with allogeneic stem cell transplants. To find that there's such exquisite targets of autologous cells just goes to show how strong a patient's own immune system against a cancer can be when we arm it in the right way.
But again, I think also the bispecific antibody CD3, CD19 worked excellent in ALL. Yeah, sure. Maybe even better than the diffuse large B-cell lymphoma. Well, the phase 2 studies are going on. We will know soon, but I think it's fascinating that these CARs seem to be another dimension compared to the BiTEs, to the bispecific T-cell engagers.
I had thought maybe the acute lymphoblastic leukemias were responding because of where the cells were and not in large nodal masses. But David showed examples today of a patient with lymphoma with very large masses responding incredibly quickly to the CAR T cells. So one of the questions that we feared before about whether these CAR T cells would be able to home into lymph nodes doesn't seem to be holding up so far.
No, not so far, but there's not much known about the fate, especially after the infusion of the CAR cells. For some days they go down and you don't find them, and then usually after 1 week they just pop up in millions of numbers of proliferating T cells.
I guess there are two other issues. One is that because it's an exciting technology, those papers tend to get published when they are published with very, very short follow-up. So we never really get a chance to see how durable the responses are. nor do you sometimes get a sense of what the long-term toxicities are. We see a lot about what the acute infusional-related toxicities are, but very little less about the fact that normal B cells are also targets of this response, loss of antibodies, and the potential for infectious complications down the way, and turning these people into individuals who aren't able to make antibodies could really be a problem for us later on.
Could be a problem, but so far infectious complications were not the major issue, as I understood
Absolutely.
Maloney. And even though it's really surprising that as long as the CARs against CD19 work, you don't have peripheral B lymphocytes detectable.
Just to comment on that also, it was interesting, a lot of these patients do get chemotherapy, Cytoxan and or fludarabine, but do they really need chemotherapy before they get the CAR T cells? I think that's a very interesting thing that's not answered yet.
Absolutely, and of course the rationales to try to both create some immunological space, and particularly a lot of people think about taking out T regulatory cells, which are often very sensitive to those particular types of chemotherapy, to allow expansion of those new T cells. But the question is, as we've evolved new technologies to develop more effective CARs, do we still need that? I don't think we know the answer to that yet.
And the only other observation that I made also is the ability, even in a patient heavily pretreated with chemotherapy, still have the ability that these CAR T cells are immunogenic and still can mount a response against the CAR T cell in some patients, which I thought was very interesting.
Sure.
Yeah.
So apart from the CAR T cells, what for you was the highlight of what we presented today, apart from your own presentation?
Apart from my own presentation and proteasome inhibition, which I thought is very interesting, the next generation proteasome Carfilzomib, of interest, we've studied that in the laboratory, appears to have, at least in different cell lines, in lymphoma cell lines as well as in primary patient specimens, we found that it has more potency than bortezomib. In our own experiments, even at a log-fold difference, a log-fold less has at least a similar killing capacity. In addition to that, we're aware from the studies mostly in myeloma that the patients actually have less in the way of neurotoxicity. Therefore, dose can probably be pushed higher. And right now we're doing a Carfilzomib plus rice combination trial in patients that are transplant eligible with relapsed refractory large cell lymphoma. Instead of just getting rice, we're understanding that from the Corral data that these patients need something else. And we've been able to demonstrate that the combination of Carfilzomib with the same agents, chemotherapeutic agents, show additive, not synergistic activity. And the hope is we'll be able to do some reversal of the chemoresistance with using a phase 1 then leading to a phase 2 study in the combination. In addition to that, we heard more today on IMiDs, immunomodulatory drugs. With respect, Andy Zelenetz talked about lenalidomide in not only a single agent but in combination therapy. We're aware that it was approved as a single agent with respect to mantle cell lymphoma not that long ago. I think what was interesting also is that where are these going to play out with respect to single or combination therapies. There's also data, as we heard from the R-squared, lenalidomide plus rituximab combinations with respect to not only in relapse in mantle cell, but in upfront mantle cell lymphoma, as well as the data from Nathan Fowler, as well as from the CLGB, as well as a very large randomized phase 3 study looking at this R-squared combination in follicular is very exciting in the upfront setting. So I think that, and then one last one that I think actually is a real exciting agent, but we're moving with caution because of initial toxicity, which actually is probably mostly an anti-tumor effect, is the ABT199, which is a BCL2 inhibitor. And we know how powerful it is that BCL2 overexpression in any tumor, in particular lymphoid malignancies, is actually always carries with it a bad prognostic type of factor. And now we have the ability of mostly purely against BCL2. In the past, ABT263 also had activity against BCL-XL, and we saw the thrombocytopenia. And even though we saw activity, we were always concerned by combining it with chemotherapeutic agents that would also induce thrombocytopenia and or maybe have we could have life-threatening bleeding if we use those combinations. That issue is not an issue with ABT199. It was purely selective for BCL2. The problem, however, at this point was so good, so the initial trials demonstrated that by using it perhaps, and it's not always dose effect, in patients who are sensitive, it can develop tumor lysis syndrome. However, in experienced hands, tumor lysis syndrome, and now changing the dose and the schedule and maybe monitoring the patients much more closely, those type of issues hopefully will not be a major concern in the future. And as we learn how to give it better, I think it's going to be a real deal changer. It's going to be a major addition to our armamentarium, as we were saying with other agents. I'm very excited looking at what's going to happen with ABT-199.
Yeah, I completely agree with you. I think even though the company themselves were very concerned by the tumor lysis syndrome, I think most trained oncologists would view tumor lysis as a sign of the activity of the drug, and therefore that we just have to learn how to handle the drug better. And certainly that seems to be the case from the more recent clinical trial data that we're seeing, and certainly from my own experience of patients that we've got on the drug, that this graded approach seems to be able to overcome the major issues and without impacting on the efficacy. It is fascinating, though, that the disease in which BCL2 has been the paradigm, that is a follicular lymphoma with a 14/18 translocation with very high levels of BCL2, it seems to be the disease in which maybe we're seeing perhaps the least signal. Just, I guess, emphasizing the importance of not just BCL2, but the other family members of BCL2 in terms of the balance that's going on. So anything surprising about the results that you saw today in terms of follicular versus non-follicular in that setting, or you knew all that already?
Well, I wouldn't say I knew it all already. I know that when we did the original phase 1/2s of 263, the activity in follicular seemed to be somewhat less. I think what's unknown so far, and we have a great interest in, is where ABT-199 will fit into with large cell. There's been an emergence of interest in overexpression of BCL2 within large cell lymphoma being associated with a poor outcome. And so it's a logical extension to think about combining a drug like this with conventional chemotherapy and seeing if we can improve the prognosis of the high BCL2, which is also associated with when combined with high MYC, seems to portend a poor outcome.
So I just want to pick up on something you were mentioning earlier. That is the big phase 3 randomized clinical trial of Lenalidomide and Rituxan, a so-called R-squared regimen compared to chemotherapy. That trial's accrued incredibly well, both in the US and in Europe. I guess perhaps highlighting the interest that patients have towards what's been termed a chemo-free approach. Now, I'll come on to that issue in a moment, because we had a very lively debate about the notion of chemo-free. But I guess what we are seeing is lots of our patients like the notion that we're moving away from what conventional chemotherapies onto more novel agents. And I guess what it's also showing is that in the right disease setting, some of these agents are able to be very effective. So we did see very promising phase 2 results coming out from the Mayo and from MD Anderson. It's in CLGB and LISA trial right now. If the results from this are indeed positive, would you see that it would be moving away from conventional CHOP-like regimens as the backbone for how we would treat follicular lymphoma patients up front?
Well, I think we're already moving away from it. Bendamustine plus rituximab is already replacing in many people's minds CHOP. I think people don't like CHOP because adriamycin is associated with hair loss, with nausea, with very low white counts. Of course, bendamustine has low white counts. But I think it's very important to recognize that we're really moving away from a conventional cytotoxic and not moving away from chemotherapy. And I think that at the end of the day, it's about therapeutic index. It's about getting the most effective therapy with the least amount of toxicity. And to the extent that R-square will give that to you in follicular lymphoma over bendamustine, rituximab, or R-CHOP, I would say that's great. But we all know that around 5 or 6% of follicular lymphoma is associated with transformation to a large cell, and I think that at least to the extent that lenalidomide has been tested as a single agent in relapsed large cell, you're just simply not going to see the same kind of long-term control. And so I think the jury's out. I think it's a very exciting regimen. I suspect it'll be I think it'll be a positive trial insofar as at least as good. And I think for the right selected patients, it probably will be a very good option for them.
I may add to that. I agree with you that our squared treatment might be the optimal initial treatment to keep the patient away as long as possible from the more conventional cytotoxic approaches. But the patient is not going to cure by this regimen, so everybody will go through the second, the third, the fourth, the fifth line, and there comes bendamustine, there comes CHOP at the end, and other.
But the only concern is what is the best sequence, and how do we avoid cross resistance? And we don't know that answer. That's the problem.
So the whole last debate that we were having, and spirited it was indeed, was this notion of chemo-free, which I think is a very attractive sounding thing for our patients. But what we came away with was that we found it very difficult to define what was chemotherapy versus what wasn't. And the notion perhaps that it was dangerous for our patients to think of chemo-free versus chemotherapy, when in fact what they ought to be thinking about was the optimal treatment approach for their disease at that stage. So what would be your message for patients coming looking for chemo-free approaches?
My message would be that these drugs are chemotherapy. They're just not a conventional cytotoxic, and that it's all about the best product, the best endpoint with the least amount of toxicity. And in fact, that may be achieved with chemotherapy plus some of these newer drugs with the chemotherapy given for very few cycles. That may be far less toxic and more effective than giving R squared for 6, 7, 8, 9 months. So I just think that we have to keep an open mind. I also think that we should also think about the fact that many conventional chemotherapy agents are actually herbal medicines. They're actual natural products, and we all know that we like to take herbal medicines. So we could say,
especially from Netherlands, from Amsterdam.
Absolutely.
Sorry.
Well, we won't go there in the U.S., but
that's true.
Many chemotherapy agents are from plants, and they're completely herbal. So we should think about it like that.
Okay, so I think we can wrap up there. Say we all agree that the right combination is the best agents that we have available for our patients. So what we've heard is another very successful day at the International Workshop from NHL with many of the world's experts in this disease coming together, discussing the latest findings. I think all of us finding it very exciting to be basing our treatments upon a better understanding of the science and the biology of the disease, and that's what we're looking to build rational approaches for going forwards. So we all look forward to next year's meeting back in Europe, and thank you very much.